Well, now I have to introduce Enrico Ferrazzi. He's coming from Milan. He's the chair in obstetrics, and he will mainly talk on the long-term consequences of pregnancy diseases for cardiovascular and metabolic diseases.
Thank you, Mina, for inviting me.
We know each other for long from the truffle group, and this is always
I prepared something more clinical, biological rather than. So probably I missed the meaning of the focus of the.
No, the focus is just
we are working in Lombardy trying to reshape the maternal-fetal perinatal network, and there were a lot of things that could be exchanged. But I'm presenting more clinical data. Well, so I will try to show how we probably misunderstand the meaning of the long-term impact of hypertensive disorder or pregnancy, putting the whole basket of the syndrome, preeclampsia, into one single, as if it was one single disease. I like to remember you where the name preeclampsia comes from. It comes from the Greek, preeclampsia, before sudden occurrence. So the first guy who introduced this term, it was in 1620. He published a book, Tractatus de Effectibus Renum et Vesicere. Okay? And then there was no PubMed. It took one century to move to the next scholar, disease of the kidney, and describes proteinuria and eclampsia. It was not until 1896 that Rita Rocci measured the pressure of women with seizures and differentiated seizures of high blood pressure and proteinuria from seizures from brain disease. So, so if we consider preeclampsia a single disease, we probably, all of us remember the studies that were performed in the 70s and 80s on the placental defective placentation. And so when we talk of preeclampsia to nurses, midwives, doctors, they all remember this story of poor placentation. Okay, so I think that most of us still consider this as the pathway to preeclampsia. Okay, and so if we consider preeclampsia a disease, not a syndrome, then we can, predict preeclampsia as if it were a single disease just by cutting the calendar into early preterm preeclampsia, which is not much more than what Varandeus was saying, that you have high blood pressure, proteinuria, and we just, after centuries, we just split it into a calendar definition. Okay? Indeed, we know that this is a paper by Figures and others, in which we started to recognize that early placentation is especially associated with early onset disease, poor early placentation, whereas predisposing cardiovascular metabolic risks might dominate the origins of late preeclampsia. So in this paper we start to understand that probably there are two different major phenotypes of preeclampsia, one based on poor placentation, one based on maternal risk for preeclampsia. And this is a paper by the collab saying that the key feature of the study of preeclampsia is recognizing the fact that it is a syndrome and not a disease. So I think everybody agrees with this now. And this is a recent paper of the British Medical Journal by Barton, Redman, Roberts, and Moffat, clearly defining the early onset form is predominantly due to defective placentation during the first few weeks of pregnancy, and late onset preeclampsia appears to be driven by oxidative changes in the placenta, induced by progressive mismatch between maternal perfusion and fetal placenta demand, coupled with maternal predisposition to cardiovascular disease. So the funny thing is that very important scholars define preeclampsia as a syndrome, and they identify into preeclampsia two major phenotypes. an early onset and late onset, still based on the calendar, but within the calendar, different piece of pathology is considered. And it's not all just a matter of early or late. We have evidence in pathology of the placenta that here you have incomplete spiral artery remodeling, and actually it's opposite, with aging placenta restricting intravenous perfusion. So the first image of the poor presentation, poor intervillus, a poor terminal villi is opposite here. You have immature proliferating villi near term. So two different placental pathologies, which with the same oxidative stress of the syncytial trophoblast. But again, the diagnosis of preeclampsia in 2019 is still based on Rivarocci and Prederayet criteria. Plus, if you read hypertension, the paper by the International Society of Hypertension in Pregnancy, you just add everything. You have high blood pressure and every disease in the world, diabetes, immunologic disease, anticardiolipin, everything. Okay, so we are in the middle of a transition here. Okay, so if you go and read the more recent papers on the long-term effect, you still have to consider that these two major phenotypes are put together as if they were single disease, and the long-term outcome is considered as if these two different diseases are one single. So I just report two different ways to look at long-term, to measure the long-term effect. This is a systematic review and meta-analysis. We reviewed everything of women who suffered of preeclampsia and eclampsia, and 10 years later they measured blood pressure, systolic, diastolic, lipid profile, everything, and they just report one diastolic blood pressure in women affected, 3,000 over 13,000, and obviously those who suffered of preeclampsia, they have a higher diastolic pressure, they have higher systolic pressure, they have an abdominal lipid profile, so on and so forth. So apparently the model is coherent. You just consider preeclampsia, the disease, not a syndrome. You look 10 years later and there's apparently similar cardiovascular and metabolic risk factors higher in those who suffered of preeclampsia. This is another way to look at the long-term effect. This nation-based cohort study. It's about 15 million women, and those who suffered of hypertensive disorder of pregnancy, which to me is a much better way to consider a syndrome, hypertensive disorder, not preeclampsia, and those who suffered of preeclampsia or hypertensive disorders, and these are the ages of their pregnancy. You see an increasing rate of incident of hypertension. Okay, these are the cumulative incidence of hypertension in years time since first birth. But it's quite clear that if you suffer preeclampsia or hypertensive disorders, years later you have much higher risk of suffering of cardiovascular disease than those who did not suffer any hypertensive disorder. So what I'm trying to do in the next part of my presentation is to show that we can differentiate hypertensive disorder into two main different phenotypes, and possibly then consider a different way to prevent the risk of developing cardiovascular disease later in life. In fact, one of the data reported by this nationwide cohort study is that non-intensive pregnancy, the rate of women with a BMI heavier than 30 or 35 is 7%. And in gestational hypertension and preeclampsia, it is twice as much and 3 times as much. Okay, so if you're obese, you have a higher risk of gestational hypertension and moderate preeclampsia. So we are now moving into the proxy of metabolic syndrome, obesity. So proxy of metabolic syndrome means a proxy of a different way to develop hypertension in pregnancy rather than just because of poor presentation early in pregnancy. This is a study, again, the Hunt 1 and Hunt 2 study is a Norwegian-based population study, and probably Torben knows this much better than I do. And they sorted out 3,000 women out of 25,000, longitudinally studied with all the data on blood pressure, lipid profile, etc. And of course, 10 years later, they found a correlation between obesity and abnormal lipid profile and hypertension with developing cardiovascular disease later in life. But when this was adjusted for body mass index, the relative weight of what was happening in pregnancy was overshadowed by what was occurring before pregnancy. So the conclusion is that these results suggest a positive association of preeclampsia and gestational hypertension with post-pregnancy cardiovascular risk factors may be due largely to shared pre-pregnancy risk factors rather than reflecting a direct influence of the hypertensive disorders. So we now see that a huge amount of preeclampsia and hypertensive disorders occurring in pregnancy are determined by obesity, metabolic syndrome, maternal predisposition, imposing on the Th1 environment of the placenta in the second part of gestation. And as a consequence, developing endothelial disorders and cardiovascular disease and hypertension. And these women deliver normal weight babies, even large for gestational weight babies, and not growth restricted fetuses. So it might be that it is obesity and metabolic syndrome as a cause of inflammation and long-term oxidative stress that accelerate the telomere length shortening. Okay, so these women develop cardiovascular disease later in life because of low-grade inflammation and oxidative stress ongoing for many years. There is a process of aging. So they develop hypertension because of aging, accelerated aging due to inflammation. And in fact, there is an inverse relationship between adiposity and telomere length. And you see there is a huge difference between normal weight, overweight, and obese if you measure the telomere length in leukocytes in the peripheral blood. Okay, so it's probably that we are considering pregnancy hypertension as a risk factor, and indeed it is the metabolic syndrome and obesity of these women was the cause of hypertension later in life, not hypertension. Hypertension in pregnancy might be an epiphenomenon and not the cause. This is true also for women who are delivered of growth-restricted fetuses. The telomere length is shorter in women delivering growth-restricted fetuses versus control. Now, I take a big jump, and this is a cartogram of obesity in the United States in 1998. The dimension of the circle is the number of million people, and the color is the prevalence of obesity. Okay? So in those years, only the poorer countries beyond the Appalachian, West Virginia, had obesity prevalence of 23%. That was 1998. 10 years later. This is 10 years later. Okay, not genetic changes. Okay, it's just the fast food chains development. McDonald's moved from $13 billion to $27 billion in those 10 years. Okay, so you should imagine the impact of obesity, which is now 54% in women in the United States, on cardiovascular disease. So if you forget epidemiology and put together hypertension as a single disease, you completely miss the case of how to prevent, to treat, and to prevent later in life problems with hypertension. And this is proof, this evidence that what I'm saying might be true. This is a nice study performed by Hamid Bashar in Baltimore, Maryland. He collected data in the first trimester on 3,000 pregnant women, uterine Doppler velocimetry, you know, the algorithm of the Fetal Maternal Medicine Foundation. And he rerun this algorithm on these 3,000 women. And whereas the reported sensitivity in Europe, you see here the number, 46, 81, 89, 95, 60, blah, blah, for preeclampsia, for early preeclampsia. On this cohort of women, the sensitivity was half of it. So either we in Europe were, you know, working on data to provide better results, or these are obese women in which preeclampsia has nothing to do with shallow trophoblastic invasion in the first trimester. And in fact, if you look at what is early preeclampsia in this cohort, the birth weight centile goes from 0 to 97. Big babies at 30 weeks of gestation in women with early preeclampsia, which is in our mind is that one associated with shallow trophoblastic invasion of the trophoblast. So I think that the calendar is not a good ruler for differentiating these two different phenotypes. Isn't it astonishing? You know, 97% centile, 30 weeks with hypertension. These are obese women who explode far before 34 weeks of gestation. And in fact, in that paper, in another editorial by Bashar, he proved that uterine Doppler velocimetry as a proxy of shallow trophoblastic invasion early in pregnancy and obesity are the two main drivers of hypertension disorders. So, how can we interrogate this syndrome? We have very simple way to interrogate the syndrome. Fetal growth, uterine Doppler velocimetry, maternal hemodynamic, placental pathology, markers of oxidative stress. I will try to run through these very quickly. This is an Italian study on 500 cases of hypertensive disorder of pregnancy. And this is the weight at birth of the fetuses of these 500 patients. And you see that you have in early onset, you have small babies and big babies, also here in Italy. And in late, you have big babies, normal, and growth restricted, also in late. So if we reclassify these cases into, cases with a normal uterine Doppler velocimetry, the green cases, and cases with abnormal uterine Doppler velocimetry, you split the population into two. Growth restricted along the 6th centile and normal along the 46th centile, just by adding the uterine Doppler velocimetry into that cohort. So that means that you have growth restriction from placental disorders even late in gestation. Okay? As well, you have normal babies even early in gestation. So if we don't consider this way to separate, to disentangle this syndrome, we are probably missing the point on how to predict, prevent, and treat hypertensive disorders. In that cohort, we put together this composite index of maternal risk factors: hypertension, family hypertension, chronic hypertension, gestational diabetes, pre-pregnancy BMI, maternal age. And if we consider only late onset hypertensive disorder, there was no, this index did not predict anything. The risk, the odds ratio was 1.4, but it was not significant. If we consider the same factors all along gestation, but hypertensive disorder with normally grown fetuses, then the risk factor, the odds ratio is 3 and is highly significant. So, the weeks of gestation is totally irrelevant if we want to differentiate these two phenotypes within the syndrome of preeclampsia. Uterine Doppler velocimetry, just one paper. This is a cohort of 4,000 women which were longitudinally followed up, not just first trimester screening and then the weighted birth, but they were sonographically monitored all along gestation. And if you is the mean uterine pulsatility index, selected normal cases, and the cohort classified according to early and late. There is no significant difference between unselected normal pregnancy and those who suffered of early and late. But if you classify according to HDP with a UGR and HDP with the normal fetus, then you immediately tell there is a difference, obviously. If you measure uterine Doppler velocimetry in the first trimester, it's abnormal only in cases with a shallow trophoblastic invasion, not in women who will develop hypertension because of a completely different physiology, pathophysiology. Maternal hemodynamic. This is a very important issue, and there's a lot of work and papers on maternal hemodynamics. And this is a paper we published on the American Journal thanks to the curiosity of Wilfried Geisler. This is a cohort collected in Hasselt, Belgium. Control cases, early, late, and gestational hypertension. These are the cases, and this is venous arterial pressure, heart rate, cardiac output, peripheral resistance, systolic volume, peripheral resistance. You see there is not any difference between early, late, and gestational hypertension. Cardiac output is 6.9, 7.2, 7.6, and in normal is 7.6. So, let's say there is no impact of maternal hemodynamics in these different phenotypes, early, late, gestational hypertension. But if you reclassify these three conditions into hypertensive disorder with normal fetuses and hypertensive disorder with small fetuses, you see that the cardiac output is 7.6 normal, and HTP with normal fetus and 6.5. So the low cardiac output of close-restricted fetus. There is also a paper by the group of Nicolaides on this, and Basket and Gametan, and you will see Christoph Lees as well. And also the peripheral resistances are much higher in this subgroup rather than this group. Well, I think that everybody of us now is thinking of which drug shall I use to treat a hypertensive condition in which I have high peripheral resistance, or a condition in which I have not that high peripheral resistance. If I use adrenaline in these cases, I will probably reduce the perfusion of the uterus. And because it is a high output hypertension. So this is a paper by Christoph Lees. That's the same story. The cardiac output of preeclampsia is much higher than the normal pregnancy. The cardiac output in preeclampsia with growth restriction is much similar to growth restriction, and is not that different. It's lower than control. So this is a phenotype in which the cardiac output is a poor cardiac output. So if you use hydralazine in these cases, you reduce the peripheral resistance, you improve the cardiac output, and you improve the placenta perfusion. If you use labetalol in these cases, you will probably damage both the mother and the fetus, because you further reduce the cardiac output. So blood pressure is a screening test. It's not a test you can diagnose anything. This is another paper by Christoph Lees, in which the uterine artery PI is related to the cardiac output test score to get rid of weeks of gestation. And you see that preeclampsia with fetal growth restriction and fetal growth restriction are higher uterine Doppler velocimetry, and poor cardiac output. It's just opposite what is occurring in preeclampsia. High cardiac output, low uterine Doppler velocimetry. That's you just measure the uterine Doppler velocimetry, and this is a proxy of these different syndromes. Okay. And this is what is happening 6 months after. Okay, so we have hypertension with normal fetuses. The cardiac output after pregnancy, 6 months after, goes down. And what you see in fetuses, in women with gross restricted fetuses, there is no adaptation of the cardiac output in pregnancy. So there is no reduction after. Okay, so normal women, they goes up and then they go down. And these women do not adapt. The same for TBR. TBR, it goes up here. So, I'm sorry, I'm probably pushing too many data altogether, but I want to let you feel that if we consider what is happening 10 years after pregnancy, we should probably know which kind of hypertensive disorder these women suffer. Placental pathology. There are many papers now showing that the placental pathology in preeclampsia is completely different from placental pathology in preeclampsia with fetal growth restriction. Consider the terminal villi. Here you have terminal villi like control, here are poor terminal villi, and the terminal capillaries here are similar to control and are much poorer in preeclampsia with fetal growth restriction. So there are two different lesions, incomplete spiral artery remodeling, acidoarthropathy, and hypoplasia versus villi hyperramification in maturity. So two different placental pathologies in these subsets of preeclampsia. This is a cohort of cases we studied in our hospital showing that the maternal, the poor terminal villi is much more represented in cases with growth restriction, independently of the presence of hypertension, whereas it's much less represented in hypertensive disorder with normal grown fetuses. Okay. Molecular markers of oxidative stress. This is a very simple test everybody can perform, the split PLGF ratio, okay? And this is a seminal paper published in 2006 by a group, the preeclampsia study group. Caromacci, Romero, Levine, all big names. I think that everybody must remember these slides, this figure of the paper, showing that the blocking factor here, the soluble endoglin, or split that goes up or are already up in women with preterm preeclampsia. Okay, and this is the normal cases. But if you, so it makes sense that you assume this is just differentiated by the time of onset of hypertension. But if you read the text in the results and you report the results into a figure which is much easier to remember, you see that in preterm preeclampsia, the split PLGF ratio, here it is, was abnormal only in cases with preeclampsia and growth restricted fetuses, and was normal in preeclampsia with normal fetuses. In preterm, but also in term, you have the same results in this paper, 2006. And this data went completely forgotten, okay? Because we know from 2006 that if we measure the split PLGF ratio, we can tell that here you have a placenta which whose pathology which started early in pregnancy, and here you have something different. Okay? So, according to this view, we can now differentiate hypertensive disorder in which the clinical phenotype is associated with fetal growth restriction, in which you have a shallow trophoblastic invasion, poor terminal villi, abnormal split PLGF ratio, abnormal uterine arteries, small baby, low cardiac output. Whereas here you have, and this is less than 1% of cases of hypertensive disorders. And the natural history here is that you first measure fetal growth restriction, and then in some cases the woman develops hypertension. Everybody knows that. If you have good prenatal care, universal health service with a good prenatal care, you first screen growth restriction and then hypertension. In this case, it's opposite. You have a pre-pregnancy low-grade inflammation, metabolic syndrome, dysbiosis, pro-inflammatory food, and high cardiac output or normal high PVR, normal placenta in the first trimester. You cannot screen these cases with the uterine Doppler velocimetry and PLGF. Okay? And at the end, you have pot boundary villi, as Christoph Braden calls it. You have hyperproliferation of immature villi into the intravenous space, and a mismatch between the blood coming in and circulation into the space and oxidative stress. So at the end, you have the same screening test, blood pressure inside, but the physiological condition of the two women are completely different. And probably it's completely different the way we treat them. There are ongoing studies in which the drug we choose is tailored according to the total peripheral resistances. And probably you have to prevent long-term consequences in a different way. Ok, grazie, ho finito. This is the meeting we had in